Dr. Sida Mao here to talk about a career in critical care. Sida is a critical care fellow at the QMC in Nottingham, and he's also part of the HLA Alumni and organised at the HLA conference in 2019, which was an international conference attracting high-profile speakers and participants from Europe, Africa and further afield. If you have any questions during the webinar today, please do post them in the dedicated Slack channel, and the Slack channel for tonight is hashtag critical care in the FDoc Slack. And what we'll do is we will ask Dr. Mao these questions at the end of the session. As always, if you like what we do, please tweet hashtag FDocs. And without further ado, I will pass you over to Dr. Mao. Dr. Mao, thank you for joining us today.
Thank you very much. Can everyone hear me?
Yes.
Amazing. So thanks, Hiba, for the introduction, and thank you everyone for joining me. So I'm just going to switch over to my PowerPoint now. So just let us know if you can't see that. But so we'll begin. So thanks everyone for joining in. Hiba, for giving me this platform. So again, I'm Sid. I am currently a clinical fellow in critical care in Nottingham at the moment, and today I'll be kicking off my 5-lecture series on the basic concepts of critical care medicine. So today's lecture will just have a basic overview of the underlying principles in critical care, and in the lectures in the next 4 weeks we'll explore the main concepts behind critical care, so airway, breathing, circulation, and neuro-intensive care in fitting into disability. So the reason that I want to go, the inspiration for wanting to do this is because I think critical care is such an important part of medicine, which crosses over all specialties. And I find it quite briefly taught in medical school. And in F1, F2, we are expected to go into critical care and review patients. However, not everyone has the opportunity to have any clinical experience or any training. So hopefully in this module, or in this series, in this lecture series, you can go away feeling confident and clear-headed about the underlying principles of critical care, and in your clinical practice for the rest of your foundation program, you can approach patients in critical care with a systematic approach and not be too intimidated by the complicated devices and the fancy medications that they have on the unit. So I'd like to just start with this. So Dr. Matt Morgan in March this year, in the height of the COVID pandemic, wrote this letter, and it was a response to the media's message, where commonly you would hear, don't worry, COVID is mainly affecting the elderly, the frail and the vulnerable, or those with serious underlying health conditions. And I feel like his letter, the response to the media, the response to this message highlights very well the role that critical care plays in medicine, and also the role that doctors should play in general. I've got a video in my next slide. Hopefully it works. If not, it doesn't matter. I've quoted parts of it that I think are relevant anyway. Someone just give me a message if it doesn't work, but if I hear nothing, I'll just assume it does. But if it's just silence for the next 2 minutes, we'll find a way through it. So here we go. So that was the video. I've just received a message that the audio didn't quite go through, but not to worry. I've quoted what the main parts are and what really gripped me from that lecture. So the first part is fancy machines, powerful drugs and talented staff. None of these things cure every disease. All they do is give us time. Time to work out what is wrong, time to hopefully treat it, and time for people to get better. And I think that's put really eloquently. So critical care is a supportive, we play a supportive role across all specialties. And the role that we play is just we are essentially using everything we can to buy us time so we can work with the home team to treat the underlying pathology. We reverse what is able to be reversed, but unfortunately, not all the time, not everything works. And the second quote, as you can all see, it's about essentially ceiling of care and making sure that although we have all the resources at our fingertips and we have access to fancy medications and machines, we are, at the end of the day, still doctors, and we do treat patients as a human being, not just a condition, and we will not do anything that is not in their best interests. And also the third point is the realities of critical care. And unfortunately, although we have everything at our disposal, and we are I think one of the most highly resourced departments in the hospital. Wherever you are, the intensive care unit has access to a lot of things most wards don't have. Sometimes not everything works, and it's also our duty to provide adequate palliative and good end-of-life care as well. So that brings me on to, so what is critical care medicine? And just following on from that letter is exactly those things that we discussed just now. But the definition from the Faculty of Intensive Care Medicine is treatment of patients with, at risk, or recovering from potentially life-threatening failure of one or more of the body's organ systems. So instead of grouping patients into their specific pathology, say like on the ward, they're either medical patients or surgical patients, we think of the patients regarding their physiology. And that's what we focus on, regardless of whether this patient is for surgical intervention only or medical intervention only. And that encapsulates these three things. So we offer organ system support, investigation, diagnosis and treatment of acute illness, and most importantly, I think, patient safety, ethics, end-of-life care and the support of families. And I think the last point was really highlighted during the COVID pandemic. And I remember when I was working on the unit that this was the emphasis, is that we provide good communication to families, good end-of-life care, and keeping ethics at the heart of every decision, because we do not want, although we have everything, doesn't mean we have to use everything. So critical care can then be divided into two main groups. So either level 2 or level 3 support. You might have heard these terms being thrown around, but what it essentially means is level 2 is basically just one nurse to 2 patients and only supporting one organ system only. So that is something like the high dependency unit is often a level 2 area where only one system needs to be supported. However, in level 3 is the intensive care unit. So that is where each patient has just one nurse only, and we're often supporting 2 or more organ systems there, and they're either there for invasive ventilation, which we'll cover later on, and also in later lecture series as well, or renal replacement therapy. And it's there where we do our most, I think, our most aggressive interventions. So commonly, when you step onto the critical care unit, this is what you'll see. And I certainly remember my first time stepping on as an F1, and or even as a medical student, I think there's so much going on here. It's very, very intimidating, but hopefully at the end of this lecture and after the next month, you're able to approach this sort of scenario at the end of the bed and feel much clearer about what is going on and how to navigate your way through that. And ultimately, what's your role in delivering care for this patient? So, before we move on to that, so who receives critical care? I think many of you now have spent enough time in your foundation doctor roles, and I think a good proportion of you has done out of hours work. So whether that be an evening ward cover or a night shift, and perhaps you've already encountered situations where you've been asked to review a really poorly patient and you've asked for senior support from your team, whether that is the medical registrar or the surgical registrar, and they want to make a referral to critical care. So again, when we get the bleep, so we get the bleep, and there is no real criteria, and you can't really say this is there's only 3 types of patients that move on to critical care. That's where this specialty differs from medical or surgical. We support all patients in the hospital, but there's 3 underlying questions that we always ask, and I think I've made these into the 3 R's. I think this is an easy way to think about what our decision-making process is based on. So the first R is the pathology reversible? And what I will later think, what part of their physiology is failing? Does the patient have the reserve to survive critical care? And what is the rehab potential after critical care? So in a nutshell, basically this is we're thinking to ourselves, what can we do to fix? Is there anything for us to fix? And the most important question is, does the patient have the reserve? So by reserve, we often talk about physiological reserve. And in critical care, we often like to quantify that. So the best way we quantify that is taking a good collateral history and perhaps asking, how long do you walk before you get tired? Because knowing that a patient is just independent of activities of daily living isn't enough for us to paint a picture of what would putting this patient into critical care with all those aggressive interventions and those invasive procedures, would that actually cause them more harm or cause them more or provide more benefit? And we always think a bit ahead as well. So what is the rehab potential after critical care? So when we escalate, we always think, what is the patient? Will this patient, after leaving our unit, get back to a quality of life that is acceptable? And I think all these questions are very, very hard questions to answer by yourself. And often these are discussions amongst seniors between specialties, and most importantly, if the patient is able to, with the patient themselves asking what do they want. And if the patient can't speak for themselves for whatever reason, we talk to their immediate family or next of kin. But hopefully that gives you an insight into what's going on through our heads when we get a referral. So I'll just take you through my typical day. Much like a normal day on the ward, the morning starts with handover. We have a daily review, and I'll take you through that through the remainder of this lecture. And we always get a daily consultant ward round. In the afternoon, we do our jobs. If there's any teaching opportunities, we go to that. And we always have a microbiology ward round. That's because the antibiotics are really, really micromanaged or when patients are on the unit, to ensure that that any infection or sepsis is always kept on top of adequately and appropriately. And if anyone's on the on-call, we'll receive any new admissions, emergencies inside the ward and outside the ward, and out of hours. We provide ward cover and support to our critical care outreach team, who some of you might have already encountered already, supporting the hospital at large, and going down to ED recess to review any new admissions. And I think the picture on the right, I think it encapsulates what I think we do every day. It's basically tinkering and really micromanaging. So say like this fluid management, we really, every day we make those small changes, and it's all about optimizing each system individually to make sure that the patient has the best chance of overcoming any reversible illness. So just taking you through the daily review, again, nothing fancy here. I think when I first stepped on to work in ITU during COVID, which was my first ITU experience, the first thing that the registrar told me was ITU is nothing. You can't think of ITU as anything too fancy. It's just the basics done well. And I think that stuck with me ever since. And it really is the basics, but done well. So we always review in an A, B, C, D, E, F, G format. And I think I'll take you through that individually in the next steps. And when it comes to general care, going off G, we always have a care bundle as well. And I remember when I was even on the wards, on the care of the elderly wards or surgical wards, these acronyms I would often use on my own ward rounds to make sure I covered everything. And I think for any of you watching that is interested in critical care but currently on a medical job or surgical job, but these things you can take from critical care into any job you go into. And I think on your daily ward rounds, if that's what you're doing at the moment, you can always review a patient's feed to make sure that they're getting adequate nutrition to overcome their illness, making sure that their painkillers is not, we're not overshooting it, but we're not underdosing it. Sedation is obviously critical care exclusive. VTE prophylaxis, this is a big one. No matter where you go in the hospital, this VTE prophylaxis is something that should be reviewed every day. Head of bed elevation, that's IT specific. Stress ulcer prophylaxis, that's also specific. And stress ulcer, we always treat with prophylactic omeprazole, so PPI or histamine 2 antagonist, just because it's been found that the ICU stay for a patient is so stressful such that they have such a high risk of forming stress gastric ulcers, obviously leading to potential life-threatening consequences. So we always prophylactically cover with omeprazole or ranitidine. Tight glycemic control, spontaneous breathing, whether they are trying to breathe with the ventilator or is the ventilator breathing for them. So bowel movements as well, whether the catheter is still needed or does one need to be put in, and de-escalation of antibiotics. And I think certainly a lot of these things can be taken onto the wards. And if these things are checked every day, it provides everyone, I think all patients, regardless whether they're in ITU or not, really good, highly monitored care. So just going on to the A from our daily review. So usually when we start our daily review, we have a sheet. So we have a daily review pro forma, and it actually takes us through A, B, C, D, E, F, G. And we do go through it systematically, but instead of showing you just a pro forma and talking about how to fill in the forms, I think it's much more beneficial just for me to just have just to talk about what questions are going on in our heads when we're filling out those forms. Because I remember when I first started, the consultants kept on saying it's easy filling out the pro formas just as a tick box exercise, just as a number filling exercise. But really what it's meant to do is guide you through the review of the patient and able to provide you at the end of the review with a good enough impression so you know where to take the patient next. So are they getting worse? Are they getting better? Should we be looking at them staying on ITU longer, or should we be looking at stepping them down to level 2 or back to the wards? And when we look at airway, these are the questions that's going on in my head. And so firstly, what airway do they have? So I'll be doing a lecture, I think. My next lecture will be on airway specifically, and there's a lot to say on this topic, but just from a daily review side and just a brief glimpse of what questions are going on in my head, I've just condensed it down to one slide for now. So I always ask myself, what airway is it? So the most common airways that you'll find on a level 3 unit, which is the normal IT, which is just a typical ITU, would be that they either have an endotracheal tube. So endo means that it just goes into the trachea. You can see that in the tube, there's the cuff at the end. Hopefully you can see my cursor. Just cuff at the end here, and there's the bevel, and here is where they connect it to the ventilator. So this is to make sure that the airway, this is inserted for whatever reason. And tracheostomies. So tracheostomies, I think before stepping onto ITU, my impression was that this is when you lose the airway so bad, you have to make another hole in the neck. But these are routinely used actually on the unit to wean people off invasive ventilation and wean patients off the endotracheal tube. And I'll be going through that in a lot more depth in my next lectures, but in short, wean means that you want the patient to be able to breathe off the ventilator. But if the patient is spending too long on the ventilator, we have to take an active measure to try and get the process going, to try and get them to spontaneously breathe again. And this is the next step afterwards. Obviously, there are other reasons, but 70% of the time on ITU, if you see a tracheostomy, they're most likely in short, it's called the trachewean. So what type of airway is it? Where is the airway? The obvious question is obviously down the trachea, but what I mean by that is the endotracheal tube. So specifically, how far is it in the tracheal tube? And you measure that by taking the length here and measuring up to where the trachea meets the teeth. And we measure that every day just to make sure that this hasn't changed position, because what you can risk is the endotracheal tube going too far down. And if you go back to your anatomy, the right main bronchus is more vertical than that of the left. So if the endotracheal tube goes too far down, it'll just go into the right main bronchus and only be you'll only be ventilating one lung and depriving the patient of half their lung capacity. So you want to make sure that the endotracheal tube is always in the right position. And same goes with tracheostomies as well. And why do they need this airway? And I think after reviewing each system, you'll hear me ask the same question. So why do they need an endotracheal tube at this moment? And is it still needed? And also same with the tracheostomies. Why do they need this tracheostomy? Is it still needed? How is the airway's condition? So that incorporates the condition of it. So in the endotracheal tube, is the cuff inflated adequately? Is there a cuff leak? Is there a blockage in the tube? And in the tracheostomies, much like how you assess a stoma, so site, spout, and what's coming out. So is there any mucus plugging in the trachea? Is it clean? Is it at risk of blocking it? Around the trachea site, is there any signs of infection? Is there any signs of redness? And is it in the right position? And most importantly, do they still need this airway? So typically, the longer the time a patient spends invasively ventilated, such as with an endotracheal tube or an ETT, their mortality increases every day and the complications increase every day. So the main question is, does this patient still need to be on this mode of ventilation? And if they don't need it, is this now a window of time for us to move the patient on into their journey? Because the last thing we want is patients spending longer than necessary in ICU. That is I think the purpose of the daily review is to make sure things are moving along, things aren't stagnant, and things aren't being unmonitored, because the longer the patient stays in ITU, the longer their mortality, the higher their mortality, the higher risk they'll pick up a hospital-acquired infection, and that's fatal in patients with multi-organ failure. And also it increases their chance of post-ICU delirium. It's a concept that I've recently been looking into, and it's very, very interesting. It's talking about the patient's journey after they've left ICU and how they are. And a lot of patients are left after their ICU stay with a lingering delirium, with massive psychological consequences such as PTSD and all hallucinations, and also sometimes unemployment and their social lives being massively affected. And we can really cut the chance of them experiencing the severity of these symptoms by cutting down their ICU stay where appropriate. But that's not hastening anything, but making sure they're leaving ITU at the right time, and not any later, but not any earlier. Pardon me. So going on to our next system, it's breathing. And again, don't forget the basics. So if you're asked to review an ITU patient, you can still apply those examination techniques you've been doing so well in the OSCEs and day-to-day on your job so far. So look, listen, feel. Don't be afraid to go up to the patient and assess them just as you would an unwell patient. But obviously, understandably, you'll come across this. So coming back to our chat, you'll see here, this is the ventilator. And certain, it's one of the most complicated pieces of kit, I think. It's really, whoever designed it, it really incorporates the height of physics, medicine, and it's very, very complicated. And unless you know what you're doing, I suggest but approach it with a senior. Don't go fiddling the ventilator by yourselves, especially not at FY level. So again, yes, you'll see the ventilator, and that's part of your breathing assessment here on ITU. So again, when you're looking at the ventilator, you want to know what type of ventilation they're on. So I'll be going through this in my third lecture, which is about ventilators, but in a really brief summary, you can place the mode of ventilation on a scale. So on one end of the scale, you have the patient spontaneously breathing. Right at the other end of the scale, you have the patient you have them being, so the ventilator breathing for them. And it's very, very important to distinguish right at the start what type of ventilation they're on, because within this scale there are shades of grey. So there's supported breathing. So for example, if the ventilator is breathing for them, the next thing we do to step them down and put them the next thing we do to step them down and to wean them off the ventilator is keeping them on the ventilator, but having the patient initiate the breath and then the machine doing the rest of the work for them. So it's slowly introducing that element of spontaneous breathing, but it's really, really slowly. So it's important to distinguish whether they're on BiPAP, which is biphasic positive airway pressure, or CPAP, which is continuous positive airway pressure. So what is the machine doing for them? And if you don't know, obviously ask your senior straight away. The ventilation settings, as you can see here, this is a really good diagram, because essentially this has simplified the ventilator to one simple diagram. One of my consultants told me last week that the ventilator is essentially just a big accordion. All it is just a big piece of metal pushing air into the lungs. But what we can do is manipulate every parameter of that. So manipulate the rate that it pushes it down, the pressure that it pushes it in, the pressure that it takes it out, etc., etc. So it's always important to know what type of settings they're on and what pressures they're on, because this can provide a good indicator of how the patient is in their clinical journey, in their journey in ICU. So, and at the end of the day, what does this all mean? So you'll see, so if any of you have ITU jobs, you'll call down a load of numbers, and that's all well and good, but the consultant will ask you, well, what does this mean? So what are we going to do about all this? And again, it's all taking it back to, what does this mean for the patient? Are they getting worse? Do they need longer? Are they improving? Or are they just remaining stable? It's always one of those three outcomes, but you've got to know what the numbers mean and where it fits the patient in those three categories. So again, in breathing, you want to see how the circulation is. So you're looking at ABGs, you're looking at the chest x-rays, just as you would on a normal ward. And I think it's good on ITU because you have an arterial line. So an arterial line is essentially a cannula, but that goes in your radial artery, and it provides nurses with instant access to arterial blood to do repeat ABGs without repeatedly stabbing the patient as well. And with the ABGs, again, you're looking at the numbers and you're thinking, at the end of the day, is this patient getting worse? Are they staying the same, or are they getting better? But again, in my third lecture, I'll go into ventilators in a lot more depth. But I really like that diagram because it really, really simplifies the ventilator. So circulation, and we're asking ourselves, is there adequate perfusion in the body? Again, do not forget the basics. Look, listen, feel. So taking it back to the physiology that we learnt in med school, you might recall that mean arterial pressure is the stroke volume times the heart rate times the systemic vascular resistance. And often in ITU, instead of using a normal systolic over diastolic pressure, we like to use MAP as the value that we judge adequate perfusion. And you can tell that there's three parameters that we can control here: how much the heart is pumping out, how fast the heart is pumping, and how much resistance are in the blood vessels themselves. And this is what all this fancy gadgetry is. So as you can see here, when you're making your assessment, you look, listen, and feeling. So you're looking at, are they producing any urine? What color is the urine? How do they look? Do they look dehydrated? You want to listen, and also you want to feel. So cap refill time, taking it back to the basics. But also you want to be looking at what support they're on. So by support, I mean, what medication are we giving to influence their stroke volume? What medication are we giving to influence their heart rate? And what medication are we giving to influence their systemic vascular resistance? And I'll be taking you through this in my fourth lecture about circulation and shock and support. But essentially, you might have heard NORAD, dobutamine, metraminol, all these medications influence one of these factors. And you want to know, again, how much support are we providing? So are we just providing some stroke volume? So on the wards, providing stroke volume is just fluid. So you're filling. Or are we giving something a bit extra? And why do they need support? And has it increased overnight as well? I think in ITU, the danger is that the nurses are so good at keeping their observations stable. So when you come in the morning, you'll see the obs are totally fine. And that's because the nurses have worked really hard overnight to just tweak the medication to ensure that's the case. But it's your job to see what changes are made and what these changes mean. So you might see a good map, but if the level, say, of noradrenaline has increased, you know that, okay, their blood pressure obviously was too low to be on yesterday's rate of NORAD, and today's NORAD's increased. What's changed? And again, you assess like you go through that decision tree like you would in the wards, but These are the questions we ask ourselves. And again, we take a step back and we think, what does this mean for the patient? Are they getting better? Are they just remaining stable? Or are they getting worse? And disability. So in disability, we often focus on the neuro aspect of intensive care. So I'll be covering this in my final and 5th lecture in a bit more depth. But this can be split. This assessment can be split into 2 categories. So we're assessing their brain function, and then we're assessing the amount of anesthesia we're using. So as you can see here, the assessments that we use are based on the things that you do every day as FY, on a normal medical or surgical ward, but we're adding in that bit extra. So we assess the brain every day on the wards, out of hours. Whenever you go to an acutely unwell patient, you always assess GCS, are their pupils reactive or unreactive, and do they have any neurology? And these things are honestly still the biggest indicators of brain function. And this can determine their mortality and outcome. And it's really, really crucial that we keep a track of, is their GCS falling? Are their pupils reactive or unreactive? Is only one side reactive? Has one pupil blown? Do they have new neurology? It's often more difficult in an intubated, ventilated, sedated patient to assess neurology, because obviously they're paralyzed, whatever. They're just going to be GCS3 if they're really, really sick. But we can still assess the pupils, and it's these subtle telltale signs that really give us a good indication of how this patient is doing. And obviously, so depending on whether you're in a tertiary centre or a DGH, whether neurosurgery is locally involved or not, certainly in a place with neurosurgery, I'd imagine that that any patient with a significant head injury or head bleed would have something like an ICP bolt. So this is basically a device that goes into their head, and it just keeps a track of their ICP in real time, much like and you want to see whether the ICP has changed. And ICP stands for intracranial pressure, and other monitoring as well. There's all sorts of fancy kit that we can use. In the unit that I work on, there's something that's called CFAM. Essentially, it's real-time telemetry for the brain. So it's a real-time EEG. So normally an EEG is just like an ECG. You get a snapshot from time point X to time point Y, and you see the brain trace. But with CFAM, it's continuous monitoring. And it's all those bits of fancy kit that really distinguish that ITU really has an advantage in. So again, beware delirium. You might have the patient that is awake in ICU, but again, delirium is just as dangerous on ICU as there are on the wards, and you want to be monitoring their capacity every day, what they're like. And still, if they're delirious, you still take it back to the basics and you think, what are the most common causes of delirium? So is it pain? Is it hydration? Are they constipated? Do they have an infection? It's still the basic principles that you're applying here, just with fancier kit. So with anesthesia, so we assess something called the RAS score. It stands for the Richmond Agitation and Sedation Score, and it's a score that we use to basically assess how deeply sedated we are, how deeply sedated they are. So you can see it goes from 0 to 4 and 0 to -5, and we always want to be aiming somewhere around 0 to -1, because the trouble is, if you sedate them too much, that means a greater accumulation of the anesthesia in their blood. That means a greater chance that it will take them longer to recover past their ICU delirium. But if you go too high, that's just cruel. They'll still be able to feel pain. They'll be really, really agitated and rightly so. So we really want to be monitoring their RAS score. Are they deep enough asleep? Not so much that it's dangerous, but not so much, not so little that that is cruel. And what anesthetics are we using? So you'll meet patients. So each patient will require a different amount of anesthetic and different anesthetics. And if you take it back to what you learned at med school about anesthetics, the anesthesia medication can be split into three main categories. So hypnotics, medication that paralyze, and also analgesia. So commonly, most patients will be sedated and well analgesed. So common things that we use. So short acting would be something like propofol and alfentanil. Those have very short half-lives. If you take them off the infusion, they'll often wake up very quickly. But if you want them to have a longer stay and you foresee their journey being longer, we'd often use morphine and midazolam. But the trouble is that if you have renal impairment, you might often. So if you remember that with renal impairment, morphine builds up in the blood very quickly, and again, that can have devastating effects. So they'll take them longer to wake up, increasing their mortality, increasing the chance that they'll have delirium, and increasing their stay. So it's really important that we assess this every day and get that balance right. So can we do a sedation hold? It took me about a few days into my job to work out what they meant by sedation hold. And sometimes they call it a sedation holiday. So what that means is, so say like you've assessed the patient and you think, do you know what? I think this patient is doing better. And I think we've got a window of time here to give them a good chance of getting back to normal. So what we can do is turn off the sedation for a moment of time and see what they do. And this is often used when we want to extubate a patient. And by extubate, we mean what we want to take that endotracheal tube out their throats. So if we take off the sedation, a normal healthy patient would often wake up and they think, what is going on? They'd feel the tube down the throat. They would, they're going for the tube, so they're wanting to pull it out themselves. They're giving a good cough, and that's what we want to do. That's why we want to do a sedation hold. We want to see, okay, if we turn off all the medication and de-anesthetize them, are they actually back to normal? And sometimes we find, okay, we've turned off the sedation. They're actually tolerating the airway quite well. And that's quite bad because that means they're still quite poorly. They're still so drowsy from their pathological illness to actually fight against the tube, and they have no desire. Their body isn't ready for that trial of, for that tube to come out. So that's why we do a sedation when we do disability. So electrolytes. So we're coming into the assessment. So electrolytes, we want really micromanaging their electrolytes and ITU. You might hear on the wards, treat the patient, not the numbers. In ITU, it's slightly different because we're here to micromanage and give that patient down to the decimal chance they have at reversing their pathology and giving their physiology the best chance of it to normal. So often ITU, because you're so sick, you're at high risk of malnutrition and your electrolytes go out of whack. So IV replace all these electrolytes to make sure that they're normal. And you might think when you first start, hold on, we're just doing it for the sake of the number, but it's all about optimization, and it's our role in intensive. We might micromanage these. Again, if a renal status go out of whack and you're concerned, does this patient need hemofiltration? Or filtration, and called a vas cath, and this is the line that you use to filter patients. And some common length of time is
Hi everyone, sorry about that. We're just having a technical issue, but so we will be back very, very soon, so don't go anywhere.
Can everyone hear me now?
Yes.
Oh, amazing. Sorry for that. So can someone tell me what point they lost me on?
Mid electrolytes.
Okay, can everyone hear me? Someone give me a signal, and then I can carry. Okay, amazing. Thank you, Adil. So, can everyone see my screen? Someone give me. Is that a yes? Can people see my screen before I carry on? Okay, great. So, electrolytes. Just starting from the top again. So, want to give the patients the best chance at overcoming their pathology and their physiology, making sure that it's back to normal. We really want to micromanage each of these electrolytes. To you, commonly high risk of malnutrition. Make sure that each electrolyte is micromanaged so that the physiology goes back to normal. So before I cough, I was saying that I've had a complete mind blank. So going just after that. So renal replacement. So commonly in level 3, if you go back to often get referred for hemofiltration. Remember when I was an FY1 and FY2 on medical ward, I would commonly encounter patients in such severe AKI that I am questioned, does this patient need nutrition? And again, if the answer is yes, there's definitely an indication that you should be regulating the patient for level 3 care for hemofiltration on the intensive care unit. So for those who don't know what hemofiltration is, it's essentially taking blood out of the patient, a filter, and then putting the back in the patient. So this works for them because for whatever reason, at their job of making sure that the blood is not acidotic, making sure blood is of the of potassium. If you see any of these, you should really be considering escalating, talking to your registrar or the ICU team. So if they have persistent acidemia on the VBG or the ABG, if they have a persistently raised hyperlink to treatment, that is often a sign that the kidneys are just not doing their kicking the potassium out of your. Are they fluid overloaded and output, and the oliguria or polyuric? So you're really so all of which you're thinking, okay, the kidneys are not doing its job. A device that does the job of the kidneys for them, and also uremia. And yeah, just going back to electrolytes, what I wanted to say was, on the wards, I was taught treat the patient numbers. It's slightly different. We have to make sure that give the patient to the decimal point their best chance of fighting back again, whatever their pathology is. And it's only by micromanaging these. It's our job to always enrage them so that their physiology is up to scratch. Again, the last thing that we assess is that. So even on the ward, be doing this already. This is nothing. So we really want to make sure that these patients of malnutrition. So we want to see, are their oral intake sufficient? If it's not, then we might have to get further. Do they need a nasogastric and a constant infusion of feed? They need an NJ tube. Patients with major pancreatic surgery often need both. And all else failing, do they actually within their veins? And we work closely with dietitians, and they do a really, really good, thorough assessment of where we are at in patient's nutritional state, and it's something that can be easily overlooked. And if it is, it can leave really high risk. Again, you're just prolonging their state and prolonging their mortality, the post-ICU outcome. And so this is something that you do on antibiotics. Do we need microbiology input? Nothing new there. And if they spike a temperature, they are obviously at high risk of getting infection because they have so many invasive lines in. So the typical patient will be intubated, ventilated. That's one risk of a ventilator-acquired pneumonia. Also, they'll have an arterial line. That's another infection risk. They'll have, does say that they're inserted in ED. That's 2 infection risks. They'll have a central line. They might have a vas cath as well. So we want to be looking at those lines, making sure that they're not infected. And if they are, what we're going to do about it. Are we going to take it out? Are we going to culture? What are we really going to? So what we're going to do? Do they need replacing? And anticoagulation. So I just want to leave on a note that anticoagulation is so important. It's never forget anticoagulation. Always review it every day. Do you have an accurate weight? And if you do, is that anticoagulation? You've got to work out, is it treatment or is it prophylactic? And if it's either, is the amount of anticoagulant they're that you're providing adequate for their weight? So making sure that you check on that VT weight drug chart. Are they on the right amount of enoxaparin? And if they have COVID, again, that's another procoagulant risk. And again, that will increase the amount of anticoagulation that they need to receive. So that brings us to the end of today's lecture. And I just want to thank you for everyone that's tuned in, and thanks for bearing with me during the technical faults. Just a summary of what we're going to cover in the next 4 weeks. So airways, breathing, circulation, and disability. So just going through the ABCD format, but in the airways lecture we'll go over different types of airways. We'll give a brief, a crash course in ventilators. I'll try and simplify it as much as I can, and we'll talk about support and traumatic brain injury in the neurointensive care. So thank you everyone for tuning in. Any questions, fire them on the Slack group. Feedback is most welcome. If you think I've skimmed over a point, or if there's something that you're interested in, or if you don't think this presentation style was clear enough, please let me know, and I can change that in my next lectures. I'm always seeking to try and make it as clear and as simple for you as possible. And just to take a moment, these are my contact details. Don't hesitate to drop me an email, find me on Twitter, and just get in touch. So thank you very much. Thank you very much, everyone. And I think I should be passing you back to Heba.
Hello. Oh. Hi, thanks so much, Sid, for your incredible talk. It was really insightful, and actually gave a really good summary of an introduction really to critical care. We do have one question, and that question is, let me just find it. Is a crash call dealt with differently on ITU than on the normal wards when there's a crash bleep? Oh,
One sec. Yeah. Sorry, I can't hear anyone.
Can you hear me now? Can you hear me now? Right, so I think Sid's been had a few more technical issues, so we will end it there. This talk is the introduction to a series of talks by Sid on critical care. Due to resourcing issues, the rest of the talks can only be accessed through FDocs Plus, and we make all our FDocs Plus members aware of when they're ready to be accessed. FDocs Plus has many additional benefits to FDocs, including e-learning, more virtual sim training, and virtual study days in leadership, medical education, and quality improvement, and also other podcasts and resources that you can freely access at your leisure. What's even better is that FDocs Plus can be claimed on your study budget. So if you are interested, please do drop us an email at f-docs@medics.academy. We will also be holding our normal regular events and the FDocs conference in October, so save the date, October the 3rd, and if you do have anything to present, please do apply for an oral or poster presentation. Make sure you check out our FDocs Facebook page and follow Medics Academy on Twitter and tweet #FDocs to show your support. That is it from us tonight. I hope you enjoy the rest of the evening. Keep an eye on our events and opportunities. Goodbye.